Discussions in ophthalmology. Today we're going to discuss a case of the anterior segment involving aphakia. Aphakia is a condition in which the lens is absent from its normal position. Normally, when the patient is phakic, you've got the lens here and the anterior vitreous face has a concave anterior face. Compared to when the patient becomes aphakic and the lens is absent, the vitreous tends to move forward and produces a convex appearance along with deepening of the anterior chamber and tremulousness of the iris. If there is vitreous prolapse into the anterior chamber due to complicated cataract surgery, the vitreous goes into the wound and it tends to cause peaking of the iris as well. Today we're going to discuss a case who's hypermetropic on the right side with a plus 12 diopter. On examination, she had a visual acuity of 6/18. The cornea was clear. There was vitreous in the wound going superiorly, causing updrawn pupil along with iris atrophy. The lens was absent. The patient was aphakic. There was a remnant of the anterior capsule in the inferior part of the pupil. The fundus examination was within normal limit. The other side was showing a refractive error of +6 with the correction of 6/18. Previously, the patient had been a +10 diopter hypermetrope. The hypermetropia had decreased over years because of the presence of nuclear sclerosis. Examination, she had a nuclear sclerosis of +4. Otherwise, the anterior segment examination was normal, except that the anterior chamber was shallow due to the thickening of the lens. Here we can see this is a picture. On the anterior segment, we're going with a slit examination on a low magnification. You start off, you see and you can increase this beam to a full thickness beam. With a slit beam, this increase the magnification of the beam. If you see the beam, it shines anteriorly on the anterior surface of the epithelium and the posterior surface of the endothelium, then on the anterior surface of the iris. The distance between these two beams is the thickness or the depth of the anterior chamber. This depth is narrow in the periphery but tends to become deeper in the center. Here you can see this distance become wider. So this patient is aphakic and you can see these whitish patches on the iris. On retroillumination, you see there's remnant of the capsule with abortive lens fibers in it. There's transillumination of the iris overhead due to iris atrophy. This iris atrophy is going to be more visible when you go on for a diffuse light examination of the anterior segment. If we increase the light, you can clearly see this atrophy of the iris over here as well. You can see the pupil is vertically oval and it is peaked superiorly, and this peaking is secondary to the presence of vitreous in the wound. So next, what you want to do is to clearly identify the vitreous in the anterior chamber. You can make the slit narrower and increase the magnification. Look for any vitreous over here in this area. If the vitreous globule is present here, that means a good anterior vitrectomy has not been done. But in this case, the vitrectomy had been done. There was no vitreous present in the pupillary area, but there was only vitreous going into the wound, which was a very small wick of the vitreous. The next question is, can you see that wick? Yes, you can see that wick. You go onto a higher magnification, and here you can see the pupil going upward, and the wick is present over in this area, which can be clearly seen over here. Here you can see that strand going into this area. And initially, when you've done your cataract surgery, you might even see that vitreous coming out from the wound in the initial few days. It is important to lyse this wick of vitreous in order to prevent any traction, because whenever the pupil constricts, this wick is going to be pulled downward. That pulls on the vitreous all the way back to the vitreous base, causing retinal tears. That is the importance of clearing the vitreous in the wound at the time of cataract surgery, and if it's present later on, you can clear that as a secondary procedure as well. Aphakia has got its own other problem associated with it, which can be cystoid macular edema. It's present in some of the cases. And then glaucoma is another entity which is also present in cases. Now we're going to look at the pathology on the other side. The lens over here is nuclear sclerotic. As we told, we had nuclear sclerosis +4, and due to that there is shallowing of the anterior chamber, so the distance between the cornea and the iris becomes shallower compared to a normal eye. So that's called the lens iris diaphragm has moved forward. In order to grade a patient with cataract, you need to grade their in 3 steps. One is nuclear, the other is cortical, and then is the posterior subcapsular part of the cataract. For the nucleus sclerosis, you would make a slit as we had shown you earlier, and then you grade the nucleus according to the appearance of the nucleus, starting off from a light green to darkish green with yellow and brownish appearance in nucleus +4. In cortical opacities, similarly, you do a red retroillumination or red reflex examination, and you would grade the cortical spokes. And posterior subcapsular cataract, you also do a red reflex or retroillumination to grade the posterior subcapsular cataract, which is +4 in this patient. Once you've graded your cataract, you come on to your anterior segment examination. Here is a low magnification examination. You can see the anterior central part of the anterior chamber depth is pretty shallow, and as we move the width to the periphery, it becomes even shallower. Then you do a diffuse illumination, and once you do a diffuse illumination, you can also look at the palpebral and the bulbar conjunctiva, look at the lid margin for any notching of the lid due to blepharitis, look at the puncti if there's any regurgitation, especially in a patient with cataract. Then you would go on to change your slit to higher magnification. You make your slit thinner to examine the anterior segment in detail. And once you've seen the angle depth, then you would, hey, I'm trying to check the ended, you tend to check the ended anterior chamber depth temporally and nasally on both sides, and superior and inferiorly as well. And once you've done that, you look for the nucleus sclerosis. Here you can see the anterior capsule of the lens, and this is the nucleus sclerosis, which is starting right up from the anterior capsule. So that means it's pretty dense cataract. We did not dilate this patient because she had a shallow anterior chamber, and this would have caused an angle closure glaucoma attack. So you grade the nucleus sclerosis. You can see going backward, it looks more of a brownish appearance. So it's an NS4 cataract. At the end, I would like to show you what an aphakic glasses looks like. This is another patient who presented in which we are showing aphakia. You can see he's wearing aphakic glasses, and in these glasses the eye looks magnified in appearance. And if you see a myopic patient, the eye looks smaller in appearance. Here the forehead is shown over here being magnified in this, and these aphakic glasses tend to be a handicap for the patient because they tend to magnify the image, and aphakia as such is a handicap because the patient cannot even go to the toilet without using his glasses. While in patients with pseudophakia, they can easily move around and they only need glasses for near. So aphakia is a very important entity, and if you were doing a torch examination, the 4 most important tests which you need to know are that you'd have a jet black pupil, tremulousness of the iris, deep anterior chamber, and limbal scar which is present because of cataract surgery. Thank you very much for watching, and we'll be back with more videos soon.